Welcome to Deep Dive Ortho. Our mission is always to give you that shortcut to being well-informed, stripping away the noise to deliver the most crucial insights from orthopedic evidence directly to your clinic or theater. Today, we are tackling a particularly complex and I think a deeply practical topic, an injury that has for a long time been the nemesis of the elbow surgeon, the terrible triad injury of the elbow, or T-tie. So let's just unpack that straight away. For those who might be newer to this kind of complex trauma or perhaps just need a quick reminder of its sheer wickedness, the terrible triad is a combination of three things. You have a posterior elbow dislocation, that's one. Then it's coupled with a radial head fracture, and finally a fracture of the coronoid process. It was actually Hotchkiss who coined the term terrible back in '96, and the name just stuck, really, because the outcomes were, well, historically dreadful. We're talking notoriously challenging treatments, frequently ending in debilitating stiffness, chronic instability, and just crippling post-traumatic arthritis. The recurrence rates were huge. But that narrative has undeniably evolved. Modern biomechanical understanding and systematic surgical protocols have really shifted the prognosis. The core tension we need to resolve for you, our listeners, is this. How should the orthopedic professional approach TTIE now? How do you balance this newfound, generally positive functional outlook with what seems to be a persistently and rather stubbornly high risk of complications?
That tension is absolutely the central clinical challenge. It's vital we address it head on. If you're managing these injuries today, you need a nuanced view. Our mission is, I think, threefold. First, we have to acknowledge that contemporary surgery, driven by some very hard-won lessons, has drastically improved functional recovery. It's moved T-tie from being almost a guaranteed poor outcome to a manageable one. Second, and this is critical, we need to understand why the complication profile is still so challenging. Why are the reoperation rates still so high? What's driving that persistent stiffness? And third, we need to synthesize the latest and often conflicting evidence on prevention strategies. I'm thinking particularly of heterotopic ossification, which can so often dictate the final functional ceiling for the patient. This injury, it demands more than just technical skill. It requires a deep understanding of the biomechanical failure and really the biological anarchy that follows the initial trauma.
Okay, let's start there then by quantifying that paradigm shift. If we look back at the literature from before, say, the year 2000, the outlook really felt predetermined for functional failure. What do the contemporary systematic reviews tell us now? Are we genuinely talking about functional success being the expectation?
We are. The functional turnaround is, I think, one of the great success stories in elbow trauma management over the last couple of decades. If we synthesize the data from the big systematic reviews, and I'm thinking here of analyses covering around 16 studies, over 300 patients, the objective scoring systems, they're delivering very clear results. The mean Mayo Elbow Performance Score, the APS, which assesses pain, function, motion, and stability.
The whole picture, really.
Exactly. That score typically falls somewhere in the range of 78 to 95 points.
An MEPS score of 95 is phenomenal for an injury of this magnitude. That's suggesting near normal function, isn't it?
Precisely. And if you look at another metric, the Bruberg-Mori scores, they consistently range from 76 to 90. These numbers are so crucial because they move the conversation away from just anecdotal success to actual evidence-based outcomes. We're seeing that 70% or more of patients are achieving what we'd classify as good to excellent scores. So this means our current surgical technology and our protocols have clearly succeeded in mitigating that failure profile we used to see.
That systematic data gives us the broad strokes, but I find that newer focused institutional studies really reinforce how far we've come. For instance, a recent study from Gupta and colleagues showed very high success rates in their cohort. What were their specifics?
Yes, that cohort is highly informative. They reported a mean MEPS of 80 points, which lands squarely in that good functional category. And they confirmed that 79.2% so, nearly 4 out of 5 of their patients achieved excellent or good functional outcomes overall.
4 out of 5 patients achieving clinical success, that's a huge shift.
It is. But what's often overlooked in these score aggregations is the hard mechanical data. The actual range of motion that's achieved. The Gupta study documented a mean functional range of motion that included 112 degrees of flexion. Crucially, the average extension loss was limited to just 12 degrees.
So, on average, a 100-degree flexion-expansion arc. For anyone listening who needs context, a 100-degree arc is often what's deemed the minimum necessary functional range for most activities of daily living. To achieve that consistently after a terrible triad, That's a monumental clinical achievement.
It absolutely is. It moves the injury from being functionally crippling to functionally restored.
Yeah.
And this success confirms our understanding of the biomechanics. The T-tie is a high-energy event. It typically results from a fall onto an outstretched hand, often with the forearm supinated. The force transmits up the limb, and it drives the elbow into a state of acute valgus and axial compression.
And that specific combination of forces creates a predictable cascade of structural failure.
Exactly. The initial restraint that fails is almost always the lateral collateral ligament complex, the LCL. This is the crucial restraint against posterolateral rotatory instability. Once that LCL fails, the joint subluxates, the elbow dislocates posteriorly, and the bony impact then causes the characteristic fractures, the radial head and the coronoid process.
In the medial side.
Sometimes the medial collateral ligament fails as well, but the LCL disruption is the obligate initial pathology. That's what defines the instability pattern. The success we're now seeing simply reflects that we've finally learned the lesson. The primary aim of modern surgery is the meticulous restoration of stability at both the humeral ulnar and the humeroradial joints. Only when that stability is restored can we confidently facilitate early motion and prevent the historical enemy of TTI, that crippling stiffness.
Okay, so if improved outcomes are directly tied to achieving durable stability, what are the current non-negotiable surgical imperatives? I think looking back at those historical failures really helps to understand what we absolutely must do today.
The historical lessons are incredibly stark. They're exactly why the terrible Triad name exists. We have to anchor our current principles in studies like the one by Josephson. They looked at patients with a posterior dislocation and a radial head fracture. The critical finding was that in the 4 patients who also had an associated coronoid fracture, so the full terrible Triad, all 4 of them redislocated.
All 4?
All 4. And this was after the surgeons attempted treatment by simply excising the radial head and then just immobilizing the elbow in a cast.
That's a 100% failure rate for instability in that specific T-tie subset.
Huh.
It really cements the idea that you just cannot ignore the bony contributions to stability.
It was a recipe for disaster. This historical failure is what drove the move towards systematic protocols, most famously outlined by Pugh and colleagues. Their comprehensive approach led to fundamentally different results. In their large series of 36 patients, all treated systematically, they reported only 1 subluxation. That dramatic contrast, 100% redislocation versus 1 single subluxation, that is the foundation of modern T-tie surgery.
Right. Let's detail that modern systematic approach then, the one that differentiates successful contemporary management from those failures. What are the 3 non-negotiable steps to achieve that stability?
The modern protocol is 3-pronged. It's comprehensive. You have to address the bone and you have to address the lateral soft tissues. First, routine fixation or reconstruction of the coronoid process. If it's fractured, it has to be anatomically restored. It's the essential anterior buttress. Second, routine fixation or replacement of the radial head. This is not a secondary injury. It must be addressed either through ORIF open reduction and internal fixation or with an arthroplasty. And third, routine reattachment of the lateral collateral ligament complex back to the lateral epicondyle. You have to restore that primary posterolateral restraint.
This kind of systematic approach demands really precise classification to guide those decisions. Let's spend a bit of time on the bony classifications and, crucially, the functional implications of each type. Let's start with the radial head.
The radial head is classified using the Mason system, often with the Broberg and Mori modification. And this classification really dictates our choice between fixing it and replacing it. A Mason type 1 is a minimally displaced fracture. Now, classically, that might be managed conservatively, but in a T-tie, where stability is already compromised, it often needs fixing to ensure that radial head buttress is restored. A type 2 fracture is a displaced partial articular fracture. These are typically reconstructible, and ORAF should be the priority. You're focusing on getting an anatomical reduction and stable fixation to allow that early motion.
And the decision-making changes quite radically with the type 3, which is often cited as that tipping point towards arthroplasty.
Absolutely. A Mason type 3 is a comminuted fracture involving the entire head. It's typically deemed non-reconstructible. In this context, the radial head is vital not just for valgus stability, but for longitudinal load sharing. If you can't restore a perfect articular block, replacement is a far superior option to just taking it out. Excision in a T-tie is so strongly associated with recurrent instability. It reinforces that lesson from Josephson.
And type 4.
Type 4 simply denotes a radial head fracture with an elbow dislocation. So in the context of the terrible Triad, almost all cases are functionally a type 4. The classification helps us decide how to manage the fracture part, the I or 3.
but the Type 4 label automatically mandates surgery.
That's very clear. Now let's move to the coronoid process. It's so crucial for preventing that posterior dislocation. How does the Reagan-Mori classification guide your management?
The Reagan-Mori classification stratifies coronoid fractures based on the fragment size and, critically, the height of the coronoid involved. This directly correlates with the severity of the instability. A type I is a small tip avulsion. The fragment itself contributes very little to shear resistance. These are generally stable once you fix the radial head and LCL. Often you just need to repair the anterior capsule that's avulsed the tip, perhaps with a non-absorbable suture, the so-called lasso technique. A type 2 involves a fracture of less than 50% of the coronoid height. Now, this fragment is large enough to compromise that anterior buttress. These almost always need fixation.
So you'd use screws or a small plate for that.
Exactly. Typically cannulated screws from a posterior ulnar approach or small plate fixation to restore the geometry and stop the humerus from sliding backwards over the ulna.
And a type 3 that indicates massive instability just given the size of the fragment alone.
That's right. A type 3 is a fracture of more than 50% of the coronoid height. This is a severe disruption of the primary hinge, and it needs robust fixation. We're often relying on specialized coronoid plates or small locking mini plates to provide enough stability to allow for that early motion. Trying to manage a type 3 with simple sutures? Well, that's a recipe for catastrophic failure.
Let's connect this back to that modern cohort, the Gupta study. How did their management of the radial head reflect this rationale you've just outlined?
They showed a very pragmatic application of these rules. Radial head replacement was used in 41.7% of their cases. That proportion reflects the fact that this high-energy trauma often results in extensive comminution, your Mason type 3, that simply cannot be fixed anatomically. But, and this is key, they prioritized anatomical repair, ORAF, for all the reconstructible fractures. The principle is clear. If the articular surface can be perfectly restored, fix it. If it's irreparable, you replace it. You never want to just excise the radial head in a T-type patient. That structure provides absolutely critical valgus stability.
Moving from bone to soft tissue, we've established LCL repair is mandatory. But what about the medial collateral ligament? Is that always necessary, or can you often achieve stability just by addressing the lateral side?
The LCL complex repair is non-negotiable. Its disruption is inherent to the T-type mechanism. However, the data suggests the MCL is often spared or its damage is secondary. What's fascinating, and is exemplified in that Gupta cohort, is that medial collateral ligament repair was not required in any of their patients to get satisfactory intraoperative stability.
So you don't always have to go looking for trouble on the medial side.
It supports the robust biomechanical evidence. If you meticulously restore the bony architecture, the radial head and the coronoid, and you systematically repair the LCL complex, you often restore enough static and dynamic stability to withstand the forces of early rehab. Of course, intraoperative testing is still the final arbiter, but routine MCL repair is far less established than the absolute necessity of addressing the lateral side and the bony fragments.
You've done an excellent job showing why T-tie is no longer terrible in terms of function, 70% plus achieving good or excellent results. But this is where the conversation turns a bit more sober. We have to pivot to the flip side, the persistent high rate of complications. Despite our best efforts, what is the overall complication profile surgeons must anticipate, and why hasn't it decreased over time?
This is the area where clinical progress has lagged, and it really dictates the daily challenge of managing these patients. The systematic review data consistently highlight that the overall complication rate is stubbornly high. Looking at the cohorts, 70 out of 312 patients, that's 22.4%, required a reoperation because of complications.
That's nearly 1 in 4 patients going back to theater.
It is, and that rate ranged widely across individual studies, reaching up to 54.5% in some reports. It's a tough pill to swallow.
And it's not trending downwards despite better fixation and protocols. Why is that?
I think it just speaks to the intrinsic severity of the injury. A terrible triad is a global insult to the joint. It involves articular cartilage injury, extensive soft tissue stripping of the periosteum and capsule, and massive hematoma formation.
Oh.
We've solved the mechanical problem of primary instability with systematic fixation, but we haven't solved the biological response to severe trauma, which leads to scarring, fibrosis, and bone formation in soft tissues.
Let's break down the primary drivers of these reoperations. What are the main categories demanding a return to theater?
They're critical to anticipate. First, you have hardware-related issues. This could be hardware failure, screw pullout, or more commonly, hardware prominence or impingement that's causing pain or limiting motion, which then needs removing. Second,
and this is often the most common reason for both functional impairment and reoperation, is severe joint stiffness. This demands a formal release, or arthrolysis, which is a significant procedure to excise scar tissue and sometimes late-stage heterotopic ossification.
What about the third category, instability? You've argued modern surgery has largely eliminated that.
That's true. The third category is joint instability or redislocation, but its rate has fallen dramatically. We have to remember the historical rates. The early ring study saw a devastating 45.4% redislocation rate.
A coin toss almost.
Right. That horror rate is now close to zero in dedicated modern T-tie cohorts. When instability does happen now, it's often due to secondary trauma or failure of the original fixation, rather than a failure of the concept itself.
And the fourth critical indication for reoperation.
Ulnar neuropathy. This is a major concern. The systematic data reports rates up to 18.2% of patients needing reoperation for ulnar nerve issues. This can happen acutely from direct injury or, more commonly, as a delayed problem due to scarring and edema on the medial side. Sometimes it requires a formal ulnar nerve transposition. You have to maintain a high index of suspicion for the nerve.
Beyond reoperation, let's catalog the common complications that affect long-term recovery, even if they don't immediately lead to a salvage procedure.
The two most prominent non-operative complications are heterotopic ossification (HO) and post-traumatic arthrosis. Looking at HO, the overall incidence in the systematic reviews was 12.5%. However, that number is highly dependent on how aggressively surgeons look for it. Some earlier studies reported HO in nearly half, 48.6% of their cohort.
A huge difference.
It suggests the definition and reporting standards vary, but the risk is very much palpable.
And post-traumatic arthrosis.
Arthrosis was reported in 11.2% of patients in the modern literature. We often see grade 1 or 2 ulnohumeral arthrosis, which might be clinically mild. But again, this contrasts sharply with the pre-protocol days. That 2002 ring series, with its high instability rate, also found that a staggering 90.9% of their patients developed ulnohumeral arthrosis.
That's almost everyone.
It is. This contrast confirms a crucial point. By restoring stability, we've significantly mitigated the most devastating forms of progressive joint destruction. But mild to moderate arthrosis is still a common long-term consequence of high-energy trauma.
So, to synthesize this section, the major clinical victory is the eradication of gross instability. The remaining clinical burden is now focused on the biological consequences: stiffness, HO, and neuropathy, which still drive a high reoperation rate. This means our focus has to shift heavily toward prevention. Let's focus intensely on heterotopic ossification then, given its high incidence and its devastating potential for functional loss. For our listeners, let's start with a clear definition. We hear HO and myositis ossificans. Does that distinction carry much clinical utility?
It does, although the terms are often used interchangeably. Heterotopic ossification is the broad term. It refers to the formation of lamellar bone in any non-osseous soft tissue. Myositis ossificans, or MO, is the specific subset where that abnormal bone formation occurs within damaged or inflamed muscle.
So does that distinction actually change what you do?
The clinical utility is mostly descriptive, perhaps prognostic. If you find true HO in the joint capsule or ligaments, it's a consequence of the overall inflammatory response. If you find MO, specifically within a muscle belly, say the brachialis, it's critical to know that MO is often associated with a higher risk of recurrence if you excise it too early, before the lesion matures. But both conditions severely limit motion and often require intervention, and the outcome of that lost motion is grim. Mori's research showed that losing 50% of normal elbow motion translates to an 80% reduction in overall extremity function.
A massive functional cost. So given that risk, what are the specific predisposing factors for HO in the elbow that we must screen for?
We know HO is common after elbow trauma. The general incidence is around 30% after severe trauma, dropping to about 20% after simple dislocations. The incidence skyrockets when the dislocation is associated with fractures, as in the T-tie. And then you must screen for systemic risk factors. Patients with traumatic brain injury, TBI, who also sustain an elbow injury, have a profound risk up to 90% HO formation.
90%.
It's huge. Spinal cord injury patients are also highly vulnerable. And finally, severe burn injuries, particularly 30-degree burns over the elbow, significantly increase the risk due to the massive inflammatory cascade.
Those are the systemic factors. But there was a critical, highly specific clinical pearl you mentioned earlier relating to the initial management of the T-tie. This finding about attempted closed reductions. Could you elaborate on that?
This is perhaps the most actionable finding in recent T-tie literature. A highly specialized study found that multiple attempted closed reductions before definitive surgical stabilization was identified as a specific and incredibly powerful risk factor for HO.
How significant was that correlation?
In the subgroup of patients who underwent multiple closed reductions, a staggering 77% developed HO postoperatively. That is an enormous relative risk.
Wow, so that's almost iatrogenic in a way.
It tells us that aggressive, repeated attempts at manipulation in A&E, likely due to poor sedation or lack of initial imaging, causes massive soft tissue stripping. It further tears the already compromised capsule and periosteum, leading to expansive hematoma and a local release of inflammatory cytokines, which are potent drivers of ectopic bone formation.
That finding really changes the calculus for initial management. If the reduction is difficult, the urgency shifts from achieving a closed reduction to achieving prompt, definitive surgical stabilization to minimize that soft tissue insult.
Precisely. The longer the elbow is handled aggressively, the higher the biological toll. Surgical stabilization, even if slightly delayed for optimal timing, may cause far less biological damage than 3 or 4 failed aggressive closed reductions.
Once HO develops and starts limiting motion, diagnosis relies on clinical signs and imaging. What are the key tools for planning?
Clinically, you monitor for the telltale signs: swelling, warmth, erythema, and that progressive loss of motion. For surgical excision planning, a high-resolution 3D CT scan is absolutely essential. It precisely localizes the HO and allows the surgeon to plan the safest route for excision without damaging critical neurovascular structures.
Okay, now we arrive at the highly contentious issue of surgical timing. Historically, we were taught to wait until the HO was mature to avoid recurrence. Has that dogma shifted?
It has shifted significantly, particularly for the elbow. The old gold standards, waiting for serum alkaline phosphatase levels to normalize or relying on a negative bone scan, are largely discredited as being predictive of true maturity. A bone scan can remain positive for many months after the bone is technically mature. The current trend is towards nearer excision. While some centers conservatively wait up to 6 months, many surgeons now advocate for intervention around 3 to 4 months. The firm consensus is that it should definitely occur less than 12 months after the initial trauma.
What's driving this shift toward earlier intervention despite that theoretical risk of recurrence?
The primary driver is stiffness and contracture. If you wait too long, say 8 to 12 months, the surrounding soft tissues, the capsule, the ligaments have become severely contracted and fibrotic. Even if you successfully remove the ectopic bone, you might still be left with a joint that can't move because of profound capsular contracture.
So you're trading a risk of recurrence for a risk of permanent stiffness.
It's a critical balancing act. Delaying surgery mitigates recurrence risk, but risks a poorer functional outcome due to stiffness. Earlier intervention addresses the contracture, but carries a marginal increased risk of recurrence. For certain complex populations, like pediatric patients, we might intentionally delay due to the potential for spontaneous resolution.
Let's talk prophylaxis then. Preventing HO is always better than excising it. What are our proven options, and what's the current evidence, particularly around that conflicting data on NSAIDs and non-union?
We have 3 primary options: non-steroidal anti-inflammatory drugs, NSAIDs, external beam radiation therapy, EBCAR-T, and bisphosphonates. NSAIDs, typically indomethacin for a 4 to 6 week course, are the most common choice. They work by inhibiting the TOCAS pathway, thereby blocking the inflammatory cascade that initiates HO. The conventional wisdom, though, is always carried a severe caveat. NSAIDs can impair fracture healing, potentially causing non-union, which is a massive risk when you're relying on the union of the radial head and coronoid.
That sounds like a terrifying dilemma: prevent stiffness but risk the entire bony reconstruction failing. Is there any evidence that challenges that long-held fear, specifically in the T-tie context?
Intriguingly, yes. A provocative finding in recent literature suggests that the use of NSAIDs for prophylaxis in T-type patients may have no negative effect on clinical or radiographic non-union rates.
So that old fear, it might not hold up.
It challenges the conventional wisdom that has made many surgeons hesitant to use the most effective prophylactic agent. It suggests the biology of fracture healing in the elbow might be robust enough to withstand the systemic effects of NSAIDs. It's a crucial area for future research, but for now, it gives us more confidence to use NSAIDs, provided we monitor healing closely.
What about external beam radiation therapy, EBR?
Low-dose EBARD, typically 700 cg delivered in a single dose within 24 to 72 hours post-op, has been suggested, but the evidence for its routine use in the elbow is weak and controversial. We have to caution against widespread use because studies focusing on eBarding prophylaxis for elbow injuries have been terminated early due to high rates of adverse effects, including a demonstrable increase in non-union rates, so it remains reserved rather than a first-line option.
And finally, oral bisphosphonates.
Bisphosphonates, like etidronate, were used decades ago. They act much later in the pathway, inhibiting mineralization. However, they generally not recommended for HO prophylaxis in the elbow setting. The primary concern is that by inhibiting mineralization, they fundamentally impair fracture healing. Since successful T-time management relies absolutely on bony union, the risk usually outweighs the benefit.
So really, NSAIDs are the main player here.
For now, yes.
Once that meticulous surgical stabilization is complete, we enter the rehab phase, which is often the real tightrope walk of T-tie recovery. How do we navigate that tension between early mobilization to avoid stiffness and protecting the stability we just achieved, particularly that LCL repair?
Rehabilitation requires a structured, cooperative approach. Early controlled motion is absolutely non-negotiable for mitigating stiffness, but it must be protected. We typically initiate passive motion exercises around week 2 post-surgery. We start conservatively, focusing on a safe arc, often 45 to 100 degrees of flexion, depending on the intraoperative stability. The crucial shift must be toward active self-assisted motion. This is a key communication point with the patient. They quickly transition to performing elbow flexion, extension, and forearm rotation themselves. We need to instill what we call the healthy stretch concept. The patient must be encouraged to stretch themselves into resistance, accepting some mild discomfort. But we must explicitly forbid external forces. No aggressive passive manipulation from a therapist or family member. External force can easily exceed the load tolerance of a freshly repaired LCL.
That communication point is vital. The patient needs to understand the difference between a self-stretch and an external push. Mechanically, what is the single most crucial caution during early rehab to protect that LCL complex?
The absolute crucial caution is the kinematic restriction. You must avoid varus stress on the elbow, particularly in extension, for the initial 3 to 4 weeks. Varus stress is often generated when the patient abducts their shoulder while reaching or lifting. The LCL complex, which we've just reattached, is the primary restraint against that. Placing the arm in that position risks repair failure. Counterintuitively, overhead exercises, as long as they're performed in a plane that avoids varus loading, can actually be quite helpful for encouraging active motion and managing post-operative edema.
Moving to common post-operative issues, patients sometimes present with a worrying sign on radiographs, often termed the drop sign. How do we distinguish this pseudosubluxation from a true catastrophic redislocation?
The drop sign is a frequent cause of anxiety, but it is often a benign pseudosubluxation. It mirrors the pseudosubluxation we see in the shoulder after trauma. It manifests as a slight sag, primarily visible on lateral radiographs when the patient is upright and the arm is relaxed at their side. It's caused by the profound muscular and ligamentous injury combined with pain and guarding and a subsequent failure of the dynamic muscular stabilizers to maintain concentric reduction.
So it's a muscle problem, not a mechanical failure of the repair.
In essence, yes. The key clinical task is to distinguish this from a true subluxation that causes active articular damage. The management is non-operative, reinforce active flexion, encourage those safe overhead activities, and rigidly continue to avoid varus stress. If the joint reduces and is congruent with active muscle contraction, it's a dynamic stabilization issue, not a surgical crisis.
But if we encounter true gross instability, a severe subluxation that can't be controlled, we're in salvage territory. What are the key options for rescuing a failed stability construct?
Salvage for true instability requires an escalation of management. First, we reassess the medial side. If the MCL was left unrepaired initially, reattaching it may be required. Second, temporary rigid stabilization is often necessary. This can be achieved by cross-pinning the joint with K-wires for 2 to 3 weeks, followed by removal and immediate rehab. Or, more dynamically, we can apply an external fixator. And this leads to the distinction between static and hinged external fixators, or even an internal hinged fixator.
So what's the benefit of a hinged fixator over static pinning? It seems more complex.
It offers the profound benefit of dynamic stabilization. It provides a stable axis of rotation and prevents the subluxation while simultaneously allowing protected early range of motion.
So it lets you have the best of both worlds, stability and motion.
Exactly. It's particularly valuable in cases of severe, complex, and persistent instability, as it addresses both problems at once, ensuring stability while mitigating the risk of post-op stiffness. And a final clinical pearl on that. If the elbow is dislocated for more than about 10 days before the definitive reconstruction, you must be extremely prepared to augment that stability, either with temporary pinning or a hinge. The chronic nature of the dislocation means the soft tissues may be too compromised to hold the joint concentrically, even after a meticulous repair.
This has been an incredibly rigorous and practical deep dive. To synthesize the major shift in T-tie management for our audience, the terrible triad is no longer terrible in terms of expected functional outcomes.
That is the core takeaway. The consistent application of systematic surgical protocols, routine fixation of the coronoid and radial head, combined with systematic LCL repair, has translated into success rates where 70% or more achieve good or excellent functional scores. And critically, we have achieved the eradication of recurrent instability in the best modern series.
However, we must remain vigilant. The challenge remains the persistent high morbidity profile. The fact that approximately 22.4% of patients still require reoperation signifies that while the mechanical problem is largely solved, the biological consequences of severe trauma, namely stiffness and HO, remain difficult to manage.
Indeed. Our current best practice is founded on the meticulous restoration of the bony architecture and the systematic repair of the lateral soft tissue envelope. This mechanical competence is the enabler for the subsequent early structured rehabilitation protocol, which is now paramount to mitigating the long-term stiffness that defines the most common functional problem we face today.
If you found this deep dive valuable to your practice, please do rate and share it with your colleagues so they too can benefit from these essential clinical insights.
And for the orthopedic community, as we look towards the next generation of T-tie management, I'll leave you with this final provocative thought. Given the undeniable lack of homogeneity in these severe injuries, ranging widely in fracture configuration and soft tissue damage, and given that persistent high reoperation rate, how should we move beyond the current consensus protocols to develop truly personalized surgical and prophylactic strategies that specifically target an individual patient's risk profile for stiffness, and most importantly, for heterotopic ossification? That shift towards risk stratification and personalization is the next great frontier in elbow trauma.